Okay. Good evening once again, and welcome to the most important PYQ session for NEET for INI 2025, November 2025 from Oral Surgery. I am Dr. Himani Joshi, your original guru for oral and maxillofacial surgery. So, before we actually begin with the PYQs, let me tell you the most important topics for INI-CET. So the paper for INI-CET is mostly set by AIIMS Delhi. Alright, and two topics are the favorite of AIIMS Delhi because it's done a lot there. Okay, so the most important topics, the most important topics are trauma and TM joint. Trauma and TM joint are primarily the most important topics for oral surgery in the upcoming INI-CET. Alright, anything related to trauma, whether it is the basics, A, B, C, D, E, primary survey, secondary survey, history taking, to complex trauma, pan facial, everything, anything is very important. And TM joint. Second list, the secondary are the other things which are not done in all the places but done at AIIMS Delhi, like orthognathic surgery, pathologies, which is mostly done at all places, infections. And in pathologies and infections, what is usually asked is the clinical parts, the intraoperative parts, that is actually while doing the surgery, what is the problem or what are the things you encounter, or the complications. Mostly the focus is on the clinical intraoperative parts and the complications. Okay, this is the secondary most important things. All right, and then if the examiner feels that okay, these are BDS students, let us ask them some simpler things, then maybe they can ask some questions on distraction osteogenesis. Mostly they are image based questions, or certain questions on cleft, which are also basically embryology based questions. Or if they are in a good mood, they will put exodontia and local anesthesia. So this is the third most important set of questions, the set of topics that AIIMS will ask you. So trauma and TM joint are two topics you can't avoid, you can't leave. As old as the causes and the anatomy of TM joint, to the latest things like the arthroscopy and internal derangements, to osteochondroma, all the things are important in these two topics. So certainly if you want to start oral surgery just for INI-CET, please begin with these two topics. However, these are not the same topics, list of important topics in NEET. For example, in NEET, orthognathic surgery is not very important. Distraction is not very important. Alright, but in AIIMS it is definitely very important. Also, like I've said, please remember clinical, intraoperative and complications. These are asked a lot. Okay, so let us begin with the PYQs. We will discuss one question after the other, and after every question we will try to dissect the question and discuss the whole topic together in an hour. So beginning with the question, first question is, which of these is not a treatment alternative for enucleation in OKC? Alright, now we know that enucleation is not the correct treatment for OKC. Why? Because enucleation aims at removing the whole pathology in toto. That is possible only when it is a well encapsulated pathology. OKC is encapsulated, but the problem with OKC's capsule is OKC's capsule or the OKC lining is very thin. Alright, so even if you try to enucleate the whole pathology, mostly it will tear because it is only 4 to 6 cell layer thick. That is one of the very important reasons for the lining to stay behind, for the lining to cause recurrence. Alright, plus if you leave, even if you enucleate it completely, OKC throws up something which is known as daughter cysts or satellite cysts. Right, so if this is the mandible, and this is an OKC. Macroscopically, the extent is only within this, but microscopically, this cyst wall, the wall of the cyst has given away small satellite cysts or dotted cysts. If you enucleate, that is, just remove this part and do not treat the daughter cysts, again, these are a very important cause of recurrence, especially in the orthokeratinized variant of OKC. So, we don't just stop by doing enucleation or curettage, we go a step forward and we do certain extra things so that this and the residual lining of OKC is also removed properly. So what are the things that we do extra? We do the Cornoise solution. Yes, we put the Cornoise solution. It is a method of doing chemical cauterization. So what it will do, it's a fixative solution. What it will do, it will burn all the tissue which is around that bony socket. Second thing which we do is peripheral osteectomy. Yes, what is peripheral osteectomy? Osteo means bone, ectomy means removal. So we take a burr or a trimmer and we remove a little bit of bone around that cyst. Okay. Third thing is 5-fluorouracil. This is not very popular, but people have done it in recurrent cases and have got success. So as per latest reports, case reports and articles, 5-fluorouracil, which is an anti-metabolite drug, it is not given systemically, it is applied topically, local application in the cyst cavity, and people have got good results. The fourth option is preoperative radiotherapy. So no, radiotherapy is not a treatment alternative for any cyst. For any cyst. I mean, people can try, but never preoperatively, maybe post-op, but it's not a treatment of cysts, right? And we all know that OKC is a cyst. Initially, there was some confusion that it could be KCOT, which is keratocystic odontogenic tumor. But now we know it is not a tumor, it is a cyst. Alright, very quickly looking at the options. Peripheral osteectomy, like I've told you, we take a good, nice flame shaped or round shaped trimmer. What we do is we simply remove a little bit of bone by grinding around that socket. You see here that the cyst is already enucleated. Okay, the lining of the cyst, the wall of the cyst is removed by curettage. Okay, now whatever little bit of lining is left behind or whatever infiltration of the cyst has happened into the bone, causing daughter or satellite cysts, the trimmer will kind of remove that microscopic level of bone, and you don't need to do a resection properly, you don't need to cut that much mandible. Just take a trimmer, trim some bone, and it will be an additional thing to remove these things which can cause recurrence. Alright, so this is how you do a peripheral osteectomy. Why peripheral? Because around the cyst, in the periphery of the cyst, after enucleation, these are adjunctive procedures. Okay. Similarly, Cornoise solution, we all know about Cornoise solution. It's a fixative solution. It's made up of, that 60% alcohol, glacial acetic acid, ferric chloride and chloroform. 30% chloroform, 10% glacial acetic acid and 1 gram of ferric chloride. Alright, so this is the composition with which we mix it. We make it fresh. Always we make it in the OT just before application. In the modified Cornoise solution, in between there was a thought that chloroform is carcinogenic or it can cause problems. So modified Cornoise solution was without chloroform. It did not have chloroform. But nowadays people have come back to the original Cornoise saying that if you don't use chloroform, it is causing more recurrence. Alright, so you use it with chloroform, the original Cornoise solution. It looks like a yellowish brown colored liquid. You soak a gauze piece into it. You put that gauze piece soaked with Cornoise solution into the socket and it burns the tissues. It kind of causes fixation or burning of the tissues. So if any cyst lining is left behind, it will burn it. Plus microscopically it will go into the bone and will remove all the dead daughter cysts. Alright. So we do that alternatively. We can do one round of Cornoise, then peripheral osteectomy, then another round of Cornoise, another round of peripheral osteectomy. So this is how we go around it. Similarly, 5-fluorouracil is available in a tube. You can use that, soak it in a gauze and again pack it into the cyst cavity like this. So this is a maxillary OKC. So the teeth, the impacted teeth, the cyst lining, everything is taken out. Intraoral approach is used. A paraffin soaked gauze is put around the cyst so that the tissues do not burn, and within the cyst we have put the cornoid solution or 5-fluorouracil. Alright, so this is how we treat OKC. Okay, next we come to two questions from temporomandibular joint. These are two questions which are related. Surprisingly, both these questions were asked in the same exam. So maybe the examiner has opened up the book, he is reading certain things, and from the same paragraph or the same page, he has made up two questions. Same concept, osteogenic potential and anatomy in a child. This is the basis of the question. Okay, let's read the questions. So the question says, which of these types of condylar fractures have the highest chances of ankylosis in a skeletally immature patient? What is the meaning of skeletally immature patient? Means child, where the skeleton is not yet matured. Okay, so in a pediatric patient or in a child, what kind of fracture? So we all know that trauma is the most common cause of TMJ ankylosis, especially the childhood trauma. Okay, the child bone is highly osteogenic, lot of marrow, lot of organic content, lot of water, very little inorganic content as compared to an adult. Alright, so what fracture will cause the highest chances of ankylosis? Just if you know the anatomy, you don't even have to know the fact. Just by guessing, you can answer this question. Related to this is another question. In pediatric patients, in comparison to adults, all of these are reasons for increased chances of ankylosis except. Alright, so now we'll go to the anatomy. This is the normal condyle and coronoid process of an adult. Okay, how do we divide it? So if this is the joint capsule, okay, which contains the temporomandibular joint, the fossa, the articular disc, we know that this is the head of condyle. Alright, head is also known as capitate. So since TM joint has two condyles, dicapitular, we call it the dicapitate or the dicapitulate. Dicapitular region because two heads. This part is the neck of condyle. We all know that this is the neck of condyle. Alright. After the neck, this part, this region, this is known as the subcondylar region. Alright. So there can be fracture at all these three levels. Okay. There can be a condylar head fracture. There can be a condylar neck fracture. Or there can be like this, a subcondylar fracture like this. Okay. Now, if we see the anatomy of a child as compared to an adult, the condyles are like this. Alright. Very wide head. Very, very wide head. Hardly any neck. Hardly any neck. Very wide head. Hardly any neck. And very, very flared ramus. Slowly that flaring corrects. And it becomes more erect. Alright. So this is how a child mandible looks like, or a child condyle looks like. Alright. So hardly there is any differentiation between head, neck and other regions. Plus, the child's marrow is rich in osteogenic cells. Okay. So imagine an adult having an impact causing condylar fracture. Most common way is the neck fracture, condylar neck fracture. It is the thinnest region. It will just fracture and it will cause a problem. Whereas in a child, when the same injury reaches the joint, it causes the condyle to burst open. Alright, it causes something which is known as a burst condyle. Burst condyle. Obviously, if ankylosis has to happen, okay, the lot of theories of ankylosis, they say that, there is bleeding within the joint or there is bleeding around the joint which consolidates into the bone and it causes ankylosis. So if the bleeding is happening in the head region versus the bleeding is happening in the neck region versus bleeding is happening in the subcondylar region, which region bleeding or which region trauma will have maximum chances of causing ankylosis, which is fusion of the condyle to the fossa? Obviously, the head region, whether it is an adult ankylosis or it is the pediatric ankylosis. Any ankylosis, If there is a head fracture, especially in a child, because in a child it will like burst, all the osteogenic cells, osteoblasts, will enter into the joint. And since the healing potential of the child is so fast, it will quickly ossify into ankylosis. Alright, so with this concept, we can answer both these questions together. All condylar fractures have equal chance of ankylosis. Obviously not. Why would a subcondylar fracture have the same chance of ankylosis as a condylar fracture? Right? Second, subcondylar fractures, no. Green stick fractures, that means incomplete fractures, no. Dicapitular fractures, that means condylar head fractures. So in skeletally immature patients, even in adults, the head fractures, because the head comprises of the joint component. Fractures of this region have the highest chances of ankylosis. Similarly, what are the reasons for increased ankylosis in a child except bulbous condylar head with increased marrow content? I've just told you the head is very, very wide. It is very easy to take the brunt of trauma to the head instead of the neck. So it will burst open, causing a burst condyle. You know, it's typically called the burst condyle. So definitely it's a reason for increased chances of ankylosis in children. High osteogenic potential, definitely, as compared to adult. As we become adults, osteogenic cells reduce. Short neck of mandibular condyle, absolutely correct. Why? Because if there would have been a neck, that would fracture first. Okay, the neck would fracture like the adult. In an adult, there's a long slender neck, which is why the neck fractures happen more often. Versus a child, there is hardly any neck. It's a bulbous, very widened structure. So it's more common to have dicapitular fractures. Short neck. Increased lateral pterygoid traction. What is traction? Traction means pull. Increased pull of lateral pterygoid? No, that is not a reason. See, any muscle will become stronger with age. Alright, when you're a child, you can hardly write because your finger muscles are not strong enough. They can't hold a pencil, they can't, make those letters. Similarly, your masseters, you can't chew nuts from the day you're born, right? You're given semi-solid, then slowly solid, because your muscles, your oral musculature, slowly they will become stronger and stronger. Similarly, lateral pterygoid traction is less in children as compared to adults. In adults, definitely the lateral pterygoids are strong, they are used to eating, they are doing a lot of work, so they are strong as compared to pediatrics. So this is not a reason for having more ankylosis in children. Alright, so this is how, even from the same topic, you can have more questions, multiple questions in the same exam. So whenever you're reading a topic, please understand the concepts very, very nicely and then proceed to the next topic. Alright, I hope you're all with me, you're all understanding everything. Okay, in the end, in case you have any doubts, we'll take your doubts in the end for any question or any topic. Alright. Third question. A patient presents with deviation of chin to the right side, which is painless. Okay. Now please understand, whenever I say deviation of chin, it is not always due to ankylosis. There can be multiple reasons causing deviation of chin. Short condyle on one side or long condyle on other side can cause deviation. If it is a fracture on one side, deviation. If it is internal derangement on one side, deviation. If it is ankylosis of one side, deviation. If it is condylar hypertrophy of one side, deviation. Any unilateral process of the joint, any unilateral process, what I mean by process is any unilateral disease or pathology or condition will cause deviation of chin. Okay, when the balance is not equal, if the length is not equal, or there's tumor on one side or ankylosis or trauma, whenever it's a unilateral thing, it will cause deviation of chin. Deviation will never happen in bilateral cases. Okay. What would be your diagnosis based on the following radiograph? Okay. Now, first we have to know what radiograph it is. So, we have already taught you how to read a CT phase. So, this is a CT phase. It's a non-contrast CT of phase. This is a coronal section because it is parallel to the coronal sutures like this. This is sagittal, this is coronal, this is transverse or axial. So, this is the coronal section. What I can see here, I can see beautifully the glenoid fossa on the left side because L is marked here. I can see the beautiful glenoid fossa on the right side. I can appreciate the grey colored joint space bilaterally. I can see the joint space on the left side also. I can see nice joint space, meaning that the condyle is not fused with the glenoid fossa, neither on the right side nor on the left side. So the joint space can be appreciated. Definitely it is not ankylosis. Okay. So what is ruling out ankylosis? The joint space. I can see the normal space. Okay. Now third thing which I trace, if I start tracing from top to bottom, I am tracing the condyles. Okay. Now when I trace the condyles, I can see that this condyle has some abnormal shape like this, whereas the right condyle is quite okay. This is how a normal condyle is: the medial pole, the lateral pole, the neck, the ramus. But this particular condylar region has some exophytic growth outside the joint, some horizontal growth outside the joint. Now, the real question here is, which condition of the mandibular condyle causes a horizontal exophytic growth? Exophytic means, I say, mushroom type of growth. Alright, this kind of an exophytic growth outside the capsule. Can it be osteochondroma? Definitely, it can be a tumor which is growing in the condyle and going out. Okay, osteo means bone, chondros means cartilage, and oma means tumor. So, benign tumor of the condyles, the condylar cartilaginous region of the condyle, osteochondroma. It's the most common tumor of the mandibular condyle. Can it be a left condylar fracture? Why would a fracture cause a cauliflower-like growth in the joint? No, it can't be a left condylar fracture. Yes, deviation of chin to the right side can be because of the condylar fracture. But if I correlate that with the coronal CT given here, I can't see any breach in continuity. I can't see any fracture. Next is TMJ dislocation. Honestly, can you see a TMJ dislocation on a coronal view? No. You need a sagittal view or you need an OPG to appreciate the dislocation. Plus, the dislocation will not cause a growth like this. So, it is not TMJ dislocation. Is it condylar hypertrophy? Yes. It is a kind of hypertrophy. Means one condyle is hypertrophied. It is more, it is bigger than the other side. So, definitely it is a condylar hypertrophy. Now, here comes the confusion. Why do we choose A and not D? Or why should we choose D and not A? What is a better answer? So, if you read the prospectus of any exam, whether it is NEET or INI, you will see the words, exact words that are written in the prospectus. They are, you have to mark the best answer. It's a clear line. Take out any prospectus of NEET or INI. It's clearly written that you have to always mark the best answer. You may have multiple correct answers, or you may have multiple or all correct answers. What you have to do is you have to choose the best answer. Alright? And in this case, the best answer is not condylar hypertrophy, it is osteochondroma. As I say this, let me tell you, osteochondroma comes under the umbrella of condylar hypertrophy only. Okay? But the more precise answer is osteochondroma. How? Let us see. So, if I have to classify condylar hyperplasia, which is in short form, it is said to be CH, condylar hyperplasia. One surgeon who has done extensive work and extensive research on condylar hyperplasia is Sir Woldfort. Okay. So the Woldfort classification of condylar hyperplasia is CH type 1, CH type 2, CH type 3 and CH type 4. He has classified condylar hyperplasia into 4 types. What is condylar hyperplasia type 1? Type 1 is accelerated normal growth. That means it is not a pathology. Physiologically only, some persons have extra growth in the condyles. Okay, some people are tall, some people are short, some people are fat, some people are thin. Similarly, some condyles are naturally longer. So that comes under CH type 1. Now in that also there is a 1A and 1B. Condylar hyperplasia type 1A is when it is happening bilaterally. So whenever it is bilateral, it will never cause deviation of chin. Bilaterally there is accelerated growth. So there is mandibular prognathism. The common feature here will be prognathism. And in 1B there is unilateral accelerated growth. It is not a disease, it is not a tumor, it is just normal growth, but more on both sides, so 1A, or more on one side as compared to the other side, 1B. Believe me, if you go and look at people around you, you will find 10 people who have unequal condyles and unequal chin positions. Alright, so broadly, the vector of growth in this condition is a horizontal vector. What is the meaning of horizontal vector? That means there is a growth like this. There is a horizontal vector in growth. But it's not abnormal. It's not exophytic. It's not like this mushrooming. It is slightly more of this horizontal mediolateral component of condyle, and which is what is causing the prognathic look in the mandible. Alright, so the growth vector is horizontal in type 1 cases. The overall effect here is causing prognathism. Next we come to condylar hyperplasia type 2. This CH is caused by an osteochondroma. Any CH which is caused by osteochondroma is known as CH type 2. Obviously it's a tumor, it can't happen bilaterally. It has to happen unilaterally. Tumors को ऐसे bilaterally symmetrical नहीं होता. But here also we have 2A and 2B. What is 2A? 2A is endophytic growth. Endophytic growth means there is growth, but the growth is, so this is the condyle, the growth is like this within the condylar long axis. So it is not an endophytic growth. And what will it cause? It will cause a vertical vector of growth. Right? Whereas 2B, it causes exophytic growth. What is exophytic growth? Outside the joint capsule. So this is endophytic. This is exophytic. Outside the joint, going out of the anatomy of the condyle. And this particular type has a horizontal growth vector. Alright, so this is type 2A, this is type 2B. Both are osteochondromas. Obviously, since it's a tumor, both happen unilaterally. Both will cause deviation of chin. But the typical difference that you see on the CT scan, which is this horizontal exophytic growth. So I know it is condylar hyperplasia type 2B caused by an osteochondroma, and that is why A is the best answer. Alright. Just to finish it up, what is type 2C and type 3 and type 4? Type 3 is any condylar hyperplasia caused by other rare benign tumors. Okay, other than osteochondroma also, there are many other rarer tumors. If they are causing condylar hyperplasia, then you call it type 3. And if a malignant tumor, malignant primary, okay, not a metastatic tumor, a malignant primary tumor of the condyle is causing condylar hyperplasia, then you call it type 4. Okay, this is very, very rare. To have type 3 and type 4 is very rare. Type 2 is relatively seen, and type 1 is the most common type. Alright, so an abnormally exophytic, horizontally growing pathology within the joint has to be type 2 osteochondroma. Again, it is a type of condylar hyperplasia, which is why I was surprised when I saw this question. But since you have to choose the best answer, the answer comes out to be osteochondroma. Alright, so this should be your approach to solving the questions of the joint related to condylar hyperplasia. Alright, everybody who's watching, just give me a thumbs up in the live chat so I know you guys are with me and you guys are understanding everything. Okay, next question we come to is, name the test seen in the image below. Alright, now this is again a question on trauma. And the test that you see here is called the bowstring test. Alright, I want all of you to do one activity with me. I want you to keep one finger on the medial canthus. Okay, what is medial canthus? So this angle of the eye, medial side, is known as the medial canthus. Okay, which is on the medial side towards the nose, and where the palpebral regions meet on the outside, this is the lateral canthus. Okay, so medial canthus and lateral canthus. I have to show it on my eye. This is the medial canthus where the upper and the lower eyelids meet, and this is the lateral canthus on the outer side. The activity which I want all of you to do is, oh, so many of you are here. I just saw the live chat. Okay. Okay. Alright. So what you have to do is put one finger on the medial canthus. Put your first finger on the medial canthus. All those who are live batch students, you've already done this activity with me. Those who have not done it, please do it now. Put one finger here in the medial canthus, and with the other hand on the same eye, pull the lateral canthus away like this. What is happening? You will be able to feel the pull on the medial side also, right? You will all be able to feel the pull of the lateral canthus on the medial canthus, showing that they are actually connected together. Alright? So, the kind of test that we do here is the bowstring test. Now, what is the bowstring test? If you have seen an archer, they have a bow like this. Okay, nowadays the bows are very, very fancy, but they have bows like this, right? And then they have an arrow with which they shoot. Alright, so this string is known as the bowstring. Bowstring, this string, which is very tense, taut, and if you pull it, it will rebound. It will cause a rebound so that the arrow can be thrown forward. Similarly, this connection of the medial and lateral canthus, they are connected from a same kind of a tissue from top to bottom. If by chance there is a fracture in this region is known as the NOE region. Okay, the naso-orbito-ethmoidal region. If there is a fracture in the naso-orbito-ethmoidal region, what it will do is it will cause detachment of the medial canthus from the bone. From this region, it can cause a detachment of the medial canthus from the bone. So the tension that you feel right now when you do this bowstring test, you will not be able to feel that tension. You will be able to not palpate the nice tensed bowstring, but a loose mobile tissue in case of a fracture. So clinically, if you want to see whether it's an undisplaced NOE fracture or it's a type 1, type 2, type 3, type 1 versus type 2 and type 3, you can do that by doing the bowstring test. Alright, it's a test done to check the attachment of the MCT. What is MCT? The medial canthal tendon. What is a tendon? A tendon is a part which connects to the bone, right? So the medial canthal tendon, attachment of the MCT to the bones of NOE region. In case of fracture, if the attachment is intact, the surgery is easier. It's a simpler surgery. All you have to do is fix the bones. If the attachment is broken, if the bowstring test is positive, if the attachment is fractured, then along with the fracture repair, along with the bony repair, you have to do an extra procedure which is known as transnasal canthopexy. Transnasal canthopexy. That means apart from fixing the bones, you also have to fix the MCT back to that region. Okay, it's a long, complicated procedure. You have to take the MCT from here, pass it across the nose, and then fix it to the glabular region or somewhere. So it's an additional procedure you have to do if the bowstring test is positive. Alright, so this is about the bowstring test. Let us quickly also see what is Jones test, forced beta transferrin and forced duction test. So Jones test is basically done to check the lacrimal duct. Okay, suppose with the fracture there is an injury to the nasolacrimal duct. Okay, as the name suggests, nasolacrimal. So whatever tear is produced in the eye, okay, it is produced by the lacrimal glands which are somewhere here. So the lacrimal glands, they produce tear. They put the tear in the lateral part of the eye. It washes the whole eye. Then through the superior inferior caruncle, the tear is collected normally. They reach the lacrimal sac. From the lacrimal sac, they drain into the nasolacrimal duct and exit into the lateral wall of the nose in the inferior meatus. Right? That is why when we cry, excessive lacrimation is happening. Lot of tear is coming in the nose and we try to pull it up, which is what we say we are sobbing. Alright? So in case there is an injury to the nasolacrimal duct, so there is Jones 1, Jones 2, we will not go into detail. In case there is an injury to the nasolacrimal duct, how will you check? Okay, it will cause, clinically it will cause epiphora. It will cause epiphora. What is epiphora? Epiphora means excessive watering of the eyes. So tear can't drain through the nasolacrimal duct because it is injured or fractured. So excessive tearing will happen from the eyes. Now how can you check if it is actually patient is crying or it is an injury to the NLD? What you will do, you will put some simple dye in the eye. It should normally get collected in the superior and inferior caruncle and it should come out of the nose. So you can put a cotton swab in the nose, lateral inferior turbinate ke paas, and you will see whether that dye is coming from the nose or not. You put some colored dye, yellow, red, whatever color, and you can check. If the nasolacrimal duct is not injured, dye will come. If the nasolacrimal duct is injured, see for example here the nasolacrimal duct is injured at this position and there is discontinuity of the NLD. So the dye will be dissipated into the tissues and it will never be able to reach the inferior meatus, causing the Jones test to be positive. Okay, so this is Jones test. It is done for the checking the injury or the patency of flow in the nasolacrimal system. Okay, the next test was the beta-2 transferrin. Now beta-2 transferrin test is also known as tau protein. It is another favorite of the AIIMS examiners, the tau protein test. Okay, it's a biochemical test to check for cerebrospinal fluid. Why do we have to test for CSF? It is a brain thing. Because in a lot of skull-based fractures, okay, like LeFord2, LeFord3 or even NOE fracture, there can be leakage of CSF from the nose, known as CSF rhinorrhea. So from nose some water is coming and the patient is saying, no, I have cold. So is it the nasal secretion or is it the CSF? Okay, so you have to rule out. What you can do, you can collect that fluid. Of course, there are other clinical tests like the target sign, handkerchief test and all of that. But the real final test where you will be very sure is if that fluid contains beta-2 transferrin. It's a gold standard test for diagnosis of CSF. Beta-2 transferrin is also known as tau protein. So if in your biochemistry results, it shows that it has tau protein, that means it is not nasal secretion, it is cerebrospinal fluid. So to manage it a little more carefully, you have to give some osmotic diuretics, control the secretion of CSF, position the patient in a proper way and manage it accordingly. So this is the test for CSF. The last is the forced duction test. What is forced duction test? So it is done for trapdoor fractures of orbit where there is a muscle entrapment. So we all know that if this is the globe, the movement of the eyeball or the globe happens because of 6 muscles. What are these 6 muscles? There is the superior rectus, inferior rectus, medial rectus and lateral rectus. Along with that, there is a superior oblique and there is an inferior oblique. Alright, so these 6 muscles, SO4, LR6, REST3, controlled by the cranial nerves 3, 4 and 6. Right? So these 6 muscles cause the movement of the eyeball. Now in case all these muscles are within the bony orbit, in case there is a fracture in the orbital floor, what will happen is one of these muscles, these inferior rectus or inferior oblique, mostly the inferior rectus, it gets trapped in the fracture line. So what happens? The eye is not able to move up because the function of the inferior rectus is superior turning of the eye. So the eye will not be able to go up like this. So when you ask the patient that please follow my finger, look up, look down, look right, look left, look top right, top left. So these are the test of gaze. Clinically, you can ask the patient, you follow me and you can check the gaze. But when you take the patient to OT, you give GA, you make him unconscious. Okay. Now you have done your fracture repair. Now don't you want to check whether your repair has actually released the muscle or some part is still trapped? What will you do? The patient can't follow your instructions because he's under GA. So what you do now is you do the forced duction test. Duction means movement of eye. Forcefully, you will hold the eyeball in the inferior fornix using some non-toothed forceps, some good AdSense forceps, and you can move the eyeball in all the directions yourself. I mean, the surgeon can do it. All right, with that, he will be able to feel if it is moving very smoothly without any restrictions passively, that means the restriction is freed up. If he feels that no, roundward it is going but upward it is not able to go, that means still there is some muscle which is entrapped in the fracture line. All right, so this is the forced duction test which is done for checking the entrapment of muscle in the orbital floor. All right. Okay. So these are all the tests. These are all very, very important. We've all covered them in the lectures, but still for a revision, these are very, very important for INI-CET. All right. Next question. A patient comes after road traffic accident having displaced mandibular parasymphysis linear fracture. Okay. For closed reduction treatment in this case, what should be the ideal duration of IMF? Okay, I would answer 4 weeks because the age of the patient is not given. Age of the patient is not given, just a displaced is given and parasymphysis. I have only these 2 facts. With these facts, I will mark 4 weeks. How? How do you decide how much should be the duration of IMF? Just remember, the ideal duration of IMF is 3 weeks. Ideal duration of IMF is 3 weeks. In what cases? In young adult, in angle fractures, when the treatment is done early and when there is no tooth in the line of fracture, or the tooth is extracted or it is not there. Any fracture, angle fracture mainly, because angle fractures usually don't have teeth, they may have. It's a young adult, angle fracture, early treatment means the patient is not coming to you after 1 month when there is already some elephant footing happening in the fracture. No. The patient has come to you within 1 day, 2 days or 3 days, acute injury, and there is no tooth because tooth will slow down the process of healing because of PDL and the different kinds of tissues. It will be a slow process of healing. If there is certain things additional to this, you will keep adding weeks. For example, if there is a tooth in the fracture line, what you will do? You will add 1 week. So instead of 3, you will do it 4 weeks. Suppose the same fracture, same angle fracture, the tooth is also involved. You add 1 week, make it 4 weeks. Suppose there is instead of angle there is a symphysis fracture, symphysis or parasymphysis fracture. Again, you add 1 week. All right. If the age of the patient is more than 40 years, we know that as the person ages, the healing capacity reduces. If the age is more than 40 years, depending on the age, you add 1 to 2 weeks. Okay, suppose it's a 70-year-old patient with diabetes, with some kidney disease, with some other autoimmune conditions, obviously you will add 2 to 3 to 4 weeks also. So depending on the comorbidities, depending on the age, you will add weeks. And if the age of the patient is if the patient is a child, a pediatric or adolescent, you will subtract 1 week. So if it is the same fracture, say in a 10-year-old child, you will do IMF only for 2 weeks. Alright, so based on this calculation, the correct answer to this question, it's a parasymphysis fracture. So we will add 1 week, answer will be 4 weeks. Alright, you could add 1 more week because usually it's involving the tooth, but 5 weeks is not an option. So as the rule says, you have to choose the best answer. 2 will be too less, 8 will be too much. So 4 weeks is the best answer. Okay? Okay. The next question is treatment of ameloblastoma extending up to the inferior border of mandible is done with. Now first of all, what is ameloblastoma? Ameloblastoma is a benign odontogenic tumor. Right? And any tumor, can you treat it by curettage or marsupialization? Yes, no, of course not. Why not? Because I'm sure you all have eaten nariyal, you have drank coconut water sometime in your life, right? So when you drink your coconut water, then the malai wala, coconut wala bhaiya, he scoops out the malai from the shell and he gives you that malai. The process of scooping it out is exactly what is curettage. You take an excavator and you scoop out the lining of the pathology. This is known as curettage. Obviously, just like the malai of the nariyal is staying back, obviously you can't take out 100%, it will stay back. So just like that, if you try and do curettage in a tumor, 100% chances of recurrence. There is a line in Schaeffer's that the recurrence rate of ameloblastoma after curettage is 80 to 100%. Obviously, you will never be able to take out the whole lining if you try and do curettage. It will cause 100% recurrence. So, it is not a treatment for recurrent pathologies like tumors. You can never do it. Similarly, what is marsupialization? Marsupialization again is a treatment of cysts. Fluid-filled bags. What are cysts? Fluid-filled bags. So what you can do is, instead of taking out the whole cyst like a ranula, you can put an incision and you can open the mouth. So normally if the duct of the ranula, of the duct of the salivary gland opens somewhere here, what you can do is you can open it up, stitch it to the floor and you can cause a new opening. Instead of here, you have created a new opening here. So opening the mouth, it's a temporary treatment usually done for shrinking the cysts. Okay, usually nowadays we do Waldron's procedure. Marsupialization followed by enucleation. So temporarily just to allow the cyst to shrink a little bit to reduce the extent of surgery, you can do a marsupialization. Okay, so this is never a treatment for tumors. Tumors you can do en bloc resection or you can do complete segmental resection with reconstruction. Now here the question says extending up to the inferior border of mandible. So imagine two situations. In one situation, there is an ameloblastoma which is here. In other situation, there is an ameloblastoma like this, a big one. Will I treat both of them equally? Will I just cut out all the mandible that is there? No. I would want to preserve some part of the mandible in the first case. So what I will do, I will take a margin of 1 to 1.5 centimeter, healthy margin, and I will remove this much mandible. I will remove a block of mandible, saving the margin or continuity. Margin या continuity is preserved. So this kind of resection which preserves the continuity of mandible is known as en bloc resection or marginal resection. Opposite to that, if I do follow the same rule that 1 to 1.5 centimeters margin I have to take. So here there is no scope of margin. If I take the margin, already the lower border of mandible is involved. So I have to take to margin here, and I have to remove the next anatomical barrier also. I have to remove the periosteum also or maybe the muscle also. So when I remove this much part of the mandible, the whole segment of mandible is lost. It's not a block, it's a whole segment. So you call it a segmental resection or resection with continuity defect. There is a defect in continuity. You can't leave the mandible like that. Otherwise, this joint will be moving separately, this joint will be moving separately. So whenever you are doing a segmental resection, you have to do a reconstruction with a recon plate, any load bearing plate. Alright. So the correct answer, because it is extending up to the inferior border of mandible, the correct answer to this question is resection and reconstruction. We've already discussed this. This is the marginal en bloc resection, where you save the continuity of mandible. This is the segmental resection, where you lose the continuity of mandible. So in this case, you can't send the patient home with 2 parts mandible. You will put a load bearing plate like this, and you will bring back the continuity of mandible by putting a load bearing rigid plate like this. If there is no infection, if there is no pus, you can even put bone graft at this stage. The bone graft can be fixed with few more screws like this. If the case is infected, if there is pus, if you feel that the bone graft will fail, you can do the same bone grafting in second stage. You can do distraction in second stage or bone graft in second stage, and you will reconstruct the bone, the mandible, bony mandible. Alright, first is to reconstruct the continuity of mandible. Second is to reconstruct the height and width. And then maybe you can put some implants and put some crowns. That's at least important. Alright, so these are the treatment protocols in management of tumors. Okay. Coming to the next question. An 8-year-old boy comes with bilateral TMJ ankylosis. Okay, he's come with bilateral TMJ ankylosis. At 8 years, he has a bilateral ankylosis. Okay, so that means the normal growth of the condyle, which happens normally till puberty, till 16, 17 years of age in a boy, it has stopped completely. So his whole body is growing, his every part is growing, only the condyles are not growing. The mandible is not growing. What effect will it have on the body? He gives history of excessive snoring, continuous waking in the night with daytime somnolence. What is the meaning of daytime somnolence? Suppose a lecture is going on in the class, okay? It is some subject which you don't like. Suppose it is oral surgery and you hate oral surgery. So, sir is teaching or madam is teaching and you are doing. This is called daytime sleepiness or daytime somnolence. Not because of the lecture being very boring. Because your night sleep is fragmented. Fragmented night sleep. Since you could not sleep properly in the night, fragmented night sleep. Since you could not sleep properly in the night, you are having drowsiness in the day. You will feel that it's a small thing, but it's not a small thing. This along with the fact that he's a snorer. What does snoring mean? Snoring means airway restriction. Airway restriction is so bad that at times he's getting no oxygen, no air, making him awake in the night, continuous waking in the night. And his night sleep is fragmented, broken into parts, sleep awake because of lack of air. And this is causing him daytime somnolence, daytime sleepiness. When all this happens together, you call it obstructive sleep apnea, OSA. Very common in pediatric ankylosis, extremely common in bilateral pediatric ankylosis. Okay. Now, what will be the treatment of the same? Okay, 1 second. The treatment of this condition cannot just be the treatment of ankylosis. Okay, if this is a severe case, now classify OSA into mild, moderate and severe. It's all given in your notes. What is mild for an adult? What is mild for the pediatric? Moderate and severe. So for mild cases, you can treat ankylosis and OSA together. But in moderate and severe cases, your treatment of OSA will always be done before the treatment of ankylosis. Okay, otherwise it will worsen your airway. Your treatment surgery for ankylosis will cause the mandible to go even back and it will cause swelling in the airway. So OSA treatment is always done before ankylosis in moderate to severe cases of ankylosis. And which of these is a treatment of OSA? Is gap arthroplasty a treatment of OSA? No, it's a treatment of ankylosis. Is costochondral grafting a treatment of OSA? No, it's again an interpositional arthroplasty done for ankylosis. Is mandibular distraction a treatment of OSA? 100%. Yes, it is a treatment of obstructive sleep apnea. How? It is causing airway problem. How can a mandibular distraction correct the airway? We will just see. Wait and watch till the child attains adulthood. Absolutely not. His airway problems will cause so many complications. He will have pulmonary hypertension. He will have behavior changes. Lot of complications of pediatric OSA are seen. Alright, so you will never wait and watch. You will start treatment immediately. Okay. So, how can mandibular distraction help in OSA? Okay. First, we have to understand airway. So, this is a normal airway in a normal person. How does it begin? It begins from the nose. A patient can take air from the nose. Okay. It goes into the nasopharynx. Or if required, he can sometimes breathe from the mouth. There is a little space in the mouth also. Whatever he breathes from oral cavity or nasal cavity, it comes to the oropharynx. Nasopharynx, oropharynx. Uske niche there is laryngopharynx behind the laryngeal cartilages. And then it has two places to go. Air can either go into the airway, which is trachea, or air can go into the food pipe, which is the esophagus. Obviously, we don't want it to go into the esophagus. So, normally, God has made trachea slightly anterior. So, food will go straight into the esophagus. Air can come anteriorly and go into the esophagus. Now, the same schematic diagram, if I have to trace on a lateral ceph or on a CT, where is the airway shadow? Where is the air? So, if I trace the air, this grey shadow that you see, this is the airway. Alright, all this grey. So the air is coming here, nasal cavity, nasopharynx, oropharynx, laryngopharynx and trachea. Alright, can you all appreciate this air shadow? I will just erase it once so you can appreciate this grey air shadow, which is, very, very clear. This is epiglottis. This is again this region. You can see nice grey shadow, wide airway. It's a big highway from which air can easily go in inspiration, come out in expiration. Now, look at this X-ray of a child who has TMJ ankylosis. You see his airway, the nasal airway is probably, this is the nose, this is the lips, and this is the soft tissue chin. Instead of this chin, which should have been like this, the chin is right here. The bony chin is even back like this. What it has caused? It has caused the airway to be collapsed. Only this much airway, very narrow airway. Why? Because if you see this anatomy, the mandible is the bone which attaches the tongue, the genial muscles, the geniohyoid. The hyoid is attached to all these laryngeal cartilages. So if the mandible is pushed back, all these muscles are also pushed back. The tongue is also pushed back. Instead of the tongue coming like this, the tongue will now come like this. It will take up the whole of the posterior airway and it will eat up the airway space. So mandible is a very, very, even maxilla, but if you compare maxilla and mandible is a very important role in airway. Simply, if you take the child's mandible forward, if you just put a cut here in the mandible, put a distractor and pull this anterior part of the mandible forward, what it will do is, it will drastically bring all the soft tissues attached to the anterior mandible forward. It will bring the tongue forward. It will bring the geniohyoid and genioglossus forward. Because of that, all the tissues of the upper neck will be pulled forward and your airway will open up beautifully. Alright? So whenever you are treating a pediatric ankylosis who has moderate to severe OSA, don't treat ankylosis first. If you treat ankylosis first, what will happen? The patient will be able to open the mouth like this. And you see, when I'm opening the mouth, where is the mandible going? Even back. So imagine this child will open the mandible and mandible will go even back and his airway will just collapse. So never ever treat ankylosis alone in pediatric patients with moderate to severe OSA. Always first distract the mandible forward. You can't do an orthognathic surgery in a child. You can only do distraction. So distract it forward, correct the airway, then release the ankylosis. Alright, so this is the rule of TMJ, ankylosis and OSA. It's beautifully given in our notes also, in our videos also. Just go through them nicely so you will understand this concept very nicely. Okay, coming to the next question. I will take your questions in the end. In case some are unanswered, I will take it in the end. I hope you're all understanding. Just keep giving me thumbs up so I know that you guys are understanding. I will take your doubts. Just tell me that you are understanding. A 10-year-old child comes after road traffic accident with persistent bradycardia and hypotension. On CT, there is herniation of orbital contents. There is no fracture. There is no fracture is seen. Only what is seen? Herniation of orbital contents. What is the diagnosis? Okay. Now, this girl is saying, somebody hit me in the eye and I have got eye injury. Why? Will I believe her? Yes, I will believe her because she has a black eye. Right? This man is saying, I had a fist fight, somebody hit me on the eye and I have a eye injury, I have a fracture. Will I believe him? Yes, I will believe him. Why? Because he has a black eye. Okay, I can see there is a panda or raccoon eyes which is black around the eye, right? Because when it bleeds around the eye, it causes periorbital ecchymosis. And that ecchymosis, first it is red, then it becomes black, blue, black, like that, and slowly it resolves. So black eye. If this boy comes to me and says, I am not able to see properly, I am seeing double vision and somebody hit me in the eye or I got a ball hit under my eye, will I believe him? Say, nahi, kuch nahi hua hai. There's nothing wrong with your eyes. Why? Because he has white eye. He has a white eye. Right? These people have black eyes. But this boy can have something which is known as a white eye syndrome. Especially seen in children after orbital floor fracture. Especially seen in children after orbital floor fracture. What is white eye syndrome? We all know that in children there is green stick fracture. Green stick fracture is common in children. What is green stick? Green stick means if you have seen a tree has a green stem, a green twig which you can bend but you can't fracture it very easily. Whereas a brown stem, a brown stick which if you try to bend it will fracture. So children have a lot of organic content in their bone, a lot of water, a lot of elastic tissue. So if you fracture that, it will just one cortex will fracture, it will not completely fracture. So just like that, when there is injury to the orbital floor, when there is buckling in the orbital floor, there is a fracture. There is a fracture of the orbital floor. But the fracture snaps back. Because of the elasticity of the tissues, the floor fractures and snaps back, comes back to the correct position. Just like you open a door and you close it immediately. So, this kind of fracture is known as a trap door fracture. Why do we call it a trap door fracture? What is it trapping? Remember I talked about 6 muscles which are there in the eye. Just talked about it, right? In the NOA region. Yeah. So these 6 muscles, in this trap dooring, this inferior rectus muscle is trapped. So when you do the CT, you may not see the fracture. But you might see some soft tissue herniating through the bone. And that is a very subtle sign that there has been a fracture. Okay, so very commonly seen in children is the white eye syndrome, which is known as the trapdoor fracture of the orbital floor. Why is it important? It causes a phenomenon which is known as the OCR. What is OCR? We've already discussed it. It is the oculocardiac reflex. It's a part of the trigeminocardiac reflex which causes stimulation of the vagus nerve. Vagus nerve? Vagus nerve कहाँ से आ गई? Trigeminal nerve carries sensation from the face. The sensory nerve to the face is trigeminal nerve. V1, V2, V3. What happens is when the V1 is carrying the pain sensations from the eye after the fracture, it goes, and in the pons, in the region of the pons, there are some funny fibers, called the internuncial fibers. What happens is these trigeminal nerve fibers shake hands with the vagus nerve fibers. Now, what is the vagus nerve? The vagus nerve is the motor nerve going to the heart, having a negative chronotropic effect, negative inotropic effect. So it reduces the heart rate. So injury to the eye causing bradycardia. Injury to the eye, which is not even seen on CT because it's a white trapdoor fracture, causing hypotension. People think in the emergency room, the physician thinks that, oh, what is wrong with the heart of the child? Why is he having so much severe bradycardia? Where the child heart rate is somewhere around 80, 90, 100. Why is he having a heart rate of 50, 55? The cause is not cardiac. The cause is not neurogenic. The cause is the trapdoor fracture causing the OCR or the oculocardiac reflex. What is the treatment? Take the child to OT, just release that entrapment, give some steroids, and slowly it will correct. Alright? So this is known as the OCR. This is a very good CT telling you how a clear-cut complete fracture versus a trapdoor fracture. So you can see here, this is the normal orbit. Okay, the medial wall, the roof, lateral wall, floor, everything is intact. All the contents, you can even see the shadow of the globe, superior rectus, medial rectus, inferior rectus if you watch closely. Versus on the other side, you can see that, okay, the roof is okay, lateral wall is okay, medial wall is maybe some distortion, and this floor is definitely interrupted. Okay, so this orbital floor is fractured. All the periorbital contents like the muscles, the orbital fat, everything has come into the sinus. Alright. Whereas in this second image, in this one, you can see that this orbit is also looking fine. And broadly, this orbit is also looking fine. There is no clear-cut fracture like this case. But there is some herniation of soft tissues. This is a clue. This is a very big clue to a trapdoor fracture. So maybe the fracture happened and the bone snapped back. But in that process of opening and closing, some soft tissues came out. It could be fat. So then no problem. Slowly it will atrophy. It will not cause any problem. But if it is the muscle, it will cause multiple things. It will cause first restriction of gaze. It will cause the child inability to look upwards properly. It can cause diplopia or double vision. And it can stimulate the oculocardiac reflex, causing the cardiac changes like gastric motility changes, cardiac changes, bradycardia, hypotension, all these problems. Okay, so what you have to do you need a reconstruction of the orbital floor? No, orbital floor is fine. It is reconstructed. All you have to do is take the child to OT, open that fracture, just release those soft tissues and put them back into the orbit. Just try and put the muscles back into the orbit. That's it. You don't need a mesh. You don't need a calvarial graft. You don't need anything. Alright? So this is how you can diagnose, treat. Don't think it's a cardiac condition. It's not a cardiac condition. It is a oculocardiac reflex due to a fractured eye, a white eye syndrome. Okay? Okay. So what are the other conditions in which we can see the OCR? It can be seen in orbital fractures. It can be seen in zygoma fractures because zygoma fracture also involves the orbit and the infraorbital nerve. Just here the infraorbital nerve. Especially in children because of the trapdooring. Bilateral peripheral rhizotomy. So when you are doing that nucleus, the trigeminal ganglion treatment during TN, obviously you are treating the trigeminal nerve ka hub. So definitely it can cause a TCR. During ankylosis also, intraoperatively, suppose I am doing a very big ankylosis and the chunk is on the medial side, I'm trying to remove it. Suddenly my anesthetist is going to tell me, Doctor Sir, please wait. The heart rate is going drastically down. So we will wait. We will wait for the OCR to settle down. He will give some drugs like glycopyrrolate, which are anticholinergic drugs. Anticholinergic are vagolytic. We will give some vagolytic drugs like glycopyrrolate to prevent this OCR or to stop this OCR. And in extreme cases, we have to give other things, but usually we stop and we proceed slowly. Okay, in leaf 1 osteotomy also, if it's a small mandible, small maxilla, everything is close together. So trigeminal nerve is also there, vagus is also there. So whenever there is structures are small, in mandibulofacial dysostosis or say peri-Robin, everything is very small. So in such cases also it can cause OCR. Or when you're treating the nasopharynx, in the nasopharyngeal region also, if it's a juvenile means it's a pediatric or a pubertal nasopharyngeal angiofibroma. Again, because the child is small, the structures are close together. Even when you are embolizing that or treating that nasopharyngeal tumor, you can stimulate the OCR. So ENT surgeons, maxillofacial surgeons, and ophthalmologists most commonly encounter the TCR. Okay, it's a very important question for AIIMS. Very now and then it is asked. So please understand these concepts very nicely. Okay, next I have purposefully taken an anesthesia question because a lot of anesthesia questions are asked in AIIMS. Surprisingly, in the last AIIMS, there were 8 questions on general anesthesia related to tubes, intubation, gases, machine, phenomenon, and all of that. So I've taken one GA question. If you want to study in detail, you can go to the DBMCI MDS recorded lectures. You can watch the anesthesia recordings, beautifully recorded by Dr. Ajay Yadav, and you can watch everything in detail. Okay. For now, we'll take this question. Identify the tube below. Okay. Is it the oral preformed tube? Is it the nasal preformed tube? Is it the PVC tube? Or is it the reinforced endotracheal tube? So you have to know what is what. Okay. So very quickly, I'm just telling you, what is a tube? What is an endotracheal tube? Endotracheal tube means any tube which is connected to an anesthesia machine and it is going into the trachea to deliver oxygen and other gases to the patient when he is getting operated. Alright. So normally, initially when it started, it began with a simple PVC tube. Okay, simple plastic kind of a tube is to be done. Put the tubes, do the surgery. Slowly they realized that when you are doing oral or maxillofacial surgery in the head, so maybe an ear surgery or a cleft surgery or an ankylosis surgery, you need to move the head. And when you move the head, the tube also moves. And when the tube moves, it kinks. What happens? It kinks. What is kinking? All those who have put water in your garden using a hose pipe, you will know that sometimes when the pipe is bent, the water flow stops. Similarly, if the tube is bent, the anesthetic gases flow will stop, right? And it is very dangerous for the patient. So what developed after the simple PVC tube was the reinforced tube. Okay, the reinforced tubes, also known as the armored tube. What is armor? In the old times, these warriors used to wear this armor, shields and these elbow pads and all these metal armor, so that whatever injuries happening, they are prevented, protected, helmets. So this was their armor. So metal shield is the armor. Similarly, the same PVC tube, what they have done is they have put metal rings, multiple small metal rings like this. So it has become an armored tube. So what will happen? It will bend. It can bend left, right, but it will never kink. It will never kink. It will bend, but it will not kink. So it is a big advantage for the maxillofacial surgeons that they used to be very careful. Acha airway mud gaya, ruk jao, 10 minutes surgery will be halted and it will be very bothersome. Okay, so armored tube was a very good next generation thing which could allow some movement of the tube without the risk of kinking. But what was the problem with the armored tube? The tube is coming out from the nose or the mouth. So it's a nasotracheal tube from the nose. It's an orotracheal tube from the mouth. So it is coming out here. And suppose I am doing a leaf foot 2 fracture. I have to do a fracture here, the tube is coming out again and again. It is blocking my field. It is blocking my field of surgery. So now what can I do to do better? So if I'm doing a lower surgery, the tube should go up. If I'm doing a upper surgery, the tube should go down. So then what happened? Three people, Ring, Adair and Elvin. Okay, these are three anesthetists. They together developed what is known as the preformed tube. The preformed tubes. Okay, so they gave a preformed shape. Instead of a straight tube, they bent the tube in a certain direction. Okay, they called it the North Pole tube, also known as the nasal RAE or the nasal preformed tube, or the South Pole tube, also known as the oral RAE or the oral preformed tube. So suppose if I am doing a cleft palate, okay, you know that if I am doing a cleft palate, I have to treat the floor of the nose, I have to treat the palate, so I have to work from the oral cavity. So I can't afford to have an endotracheal tube from the nose. So I have to take an oral tube, and that oral tube will be pushed down with a retractor. So the best tube for cleft, lip and palate surgeries is the South Pole tube. How can you remember? Just remember the tip of the tube and the connector are in the same direction. The curve is such a way that the tip of the tube and the hub is in the same direction. If it is in the same direction, S for same, S for South Pole. South, north, nose is on the north and nose se tube will go upwards. Mouth is on the south as compared to the nose. So South Pole tube will go to the mouth and will go down towards the caudal end. So cranial end ऊपर जा रहा है, North Pole tube. So north, nose, N for north, N for nose, S for south, S for the same direction. So the hub and the tip are in the same direction. South Pole tube through the mouth. Where is it used? In cleft lip and palate surgeries. North Pole tube, this is the tip. Okay, if you can't see clearly, this is the tip and this is the hub. They are going out in different directions. So it will be a North Pole tube always going from the nose. You can't put a North Pole tube from the mouth. It has to be put from the nose. So it is known as a nasal RA. Where do we use it? In most of the oral surgeries. Most of the oral and maxillofacial surgeries like TMJ ankylosis, like ameloblastoma, like say an orthodontic surgery, anything. Most of the oral surgeries, if you don't have a nasal RA tube, doesn't mean you can't do the surgery. Of course, you can do that surgery with a preformed tube also, with a armored tube also, or with a simple PVC tube also. But what is best? The best is a North Pole tube. Okay, so a nasal RAE is used for most of the oral surgeries like ankylosis, right here, like TMJ ankylosis. Alright, and for cleft lip and palate, the only option is a South Pole tube. Okay, so these are the different types of endotracheal tubes. Please read about it carefully. I hope you've understood it here. So again, identify the tube. The hub is in this direction, tip is in this direction. It has a shape. PVC tubes does not have a shape. It's a straight tube like this. Reinforced tube is armored tube, doesn't have a shape. It's a straight tube. This one has a shape, but if it is in the different direction, it can't be oral. It has to be nasal preformed tube, also known as the North Pole RE. Alright, so again, I hope this is clear with all of you. Coming to the last question of the day. During extraction of maxillary premolar, like I said, if the examiner is in a good mood, he will put one exo question. Otherwise, the paper will be full of trauma, TMJ, orthognathic, infection, pathology, all of that. One of few odd extraction questions. During extraction of maxillary premolar, the root piece is dislodged into the sinus. What is the immediate step? If you know that the root piece is gone, take it out. That's the easiest thing. Blind curettage through the socket. No, you can't go anti-gravity and expect it will come out. Irrigation and suction of the cavity. See, these are all blind procedures. It may work, it may not work. Wait and watch. Never do it because you've put a foreign body into the sinus. Remove it. How can you remove it? Either through direct approach, which is Caldwell look, or through the FES, which is an indirect approach. What is FES? Functional endoscopic sinus surgery. So just like we have a laparoscope or a otoscope, just like that we have a small endoscope, just like a bronchoscope, something like that. We put it through the nose. We reach the maxillary sinus. It has a camera. It has some tissue holding ends. You locate the root piece, you hold it, and you take it out. So that's an indirect approach through endoscopy, which is known as the FES. FES is the name of the surgery. It can be done under LA or GA. Or Caldwell look, again it can be done under LA very easily. Just open into the canine fossa, create a wall, create a window in the anterior wall of the sinus, take it out, locate the root piece, take it out. Alright, so that is the correct treatment of any foreign body. It can be a dislodged root piece, it can be an implant, it can be anything. It can be sinusitis causing thickened lining. If you want to take that out, you can use these two approaches. Alright, so these are the most important questions for INI-CET November 2025. I will quickly take your questions. If they are not already answers, I will be happy to answer. Every subject's important topics, they are discussed by every faculty in the most important sessions. Srishti. So please watch all the sessions if you want to know about every subject. What is meant by 5-FU application? Yes, so 5-FU, see, fluorouracil is an anti-metabolite drug. It's a chemotherapeutic drug, which is why we don't give it systemically. I use these words specifically during that time. We don't give it systemically. It's also available in a tube for local application. Okay, it has other uses of skin application also. We use it. So just like that, we soak it in the gauze. We pack it in the cavity just like corn noise solution. And people, I've never used it personally. I've never seen anybody use it personally. But articles suggest that people around the world have used it and they found good results. So that is how you use it. We never use it systemically. Is there any specific duration of time for which we have to keep corn solution? Yes. So it's a factual thing, but different textbooks suggest different times. Okay, some say 2 to 3 minutes. So, and again, it depends on institutional protocol. So we used to follow the KGMC MAMC protocol in our PG times. So for around 120 seconds or 180 seconds like that, the HOD used to leave or the professor used to leave. Then they used to take it out. They used to do peripheral ostectomy. Again, they used to dip that gauze again for 2 to 3 minutes broadly. They used to keep it in the cavity, take it out. So broadly, we keep it for 2 to 3 minutes. Some books suggest that the first time you keep it for 7 minutes. Second time, you keep it for 5 minutes. Third time, you keep it for 3 minutes. So like that, there are different protocols. However, I don't think it is so important for exam. Just keeping it there good enough time is important. It's not a very long time. So from 2 to 3 minutes to 5 to 7 minutes, different textbooks have different answers and different articles have different answers. Modified versus non-modified have different answers. So let's not go into that. Just for a few minutes, we keep it there. Same for 5-FU also. Alright. So, increase in number of cells, that is why it is condylar hyperplasia. Increase in size of cells, it is condylar hypertrophy. Again, it's a pathology thing to discuss hypertrophy versus hyperplasia. We usually call it CH, which is condylar hyperplasia. Not hypertrophy because the size of the cell doesn't increase. It's the number of cells which increases. So, we call it condylar hyperplasia. Okay. Initially, we used to call it condylar hypertrophy, but nowadays the better term is condylar hyperplasia. Okay, I think this is Anjali Gupta. I hope that answers your question. Sunanda is saying way of teaching is nice. Thank you so much, Sunanda. Distraction need fresh bone cut. Distraction means you need to put a cut in the bone, and when the callus is formed, when the soft bone is formed, that time you have to stretch it. Okay, if you don't know the concepts of distraction, you should go to the oral surgery videos and understand the concept of distraction, because this is not the right platform to teach you the whole concept. But that's how we do the distraction. You cut the bone, you wait for secondary healing, you allow the callus to form, you pull the callus slowly at the rate of 1 millimeter per day in an adult, and after you achieve that length of bone that you want, then you stop distracting. Then you wait to let it ossify. That gives you an advancement. Alright, beyond this, you should watch the videos to understand the concept of distraction. How to treat obesity-related hypoventilation syndrome leading to OSA? You're already giving your answer, Dr. S.S. Brave. It is obesity-related. So reduce the obesity, reduce the weight of the patient. It is very common to have a bull neck and to have obesity causing OSA. Usually it's not that severe because body has a very good compensation mechanism. But if it is caused by obesity, reduce the weight of the patient, reduce the neck diameter, it will correct. With that, I tell you, since you've asked this question, there is a very nice questionnaire which is known as the Stop Bang questionnaire. Once it was asked in INI-CET, you should all know the full form of Stop Bang. What is the full form of STOPBANG? It is important for INI. It's there in the e-Gurukul question bank, PYQs, everywhere it is there. Please know the full form. You will know that how the neck circumference or obesity is causing the OSA. Alright? Alright, in RTA case, if bradycardia is seen, shouldn't we just immediately start the management of shock? Saksham Davar, is shock the only cause of bradycardia in human body? Is bradycardia only caused by shock? Only? Can there be no other reason? And if there is other reason, if there are other reasons of bradycardia, should we always treat it like shock? No, right? So if I say there is a fever, right? Fever is a symptom. Yes, I will treat the fever, but I will treat the cause of fever first. For symptomatic management, yes, I might give a paracetamol. Okay. Similarly, if I see a bradycardia, I said we will give a vagolytic drug, like we might give an atropine or we might give a glycopyrrolate. Right? So that will be the symptomatic management of bradycardia. But what is causing the bradycardia? Is it a hypovolemic shock? I can't see any trauma. The child has come walking to me with no evidence of injury. So how will I consider hypovolemic shock as the cause of bradycardia? Why will I consider cardiogenic shock as the cause of bradycardia? Since it's a fresh trauma, why will I consider septic shock as a cause of bradycardia? Patient has not had any drugs. Why will I consider anaphylactic shock as a cause of bradycardia? Why will I think of shock? Right? So every time when you see bradycardia, exactly this is what the examiner is asking you. Will you think of a cardiac cause? Or can it be caused by other things like an eye trauma? Right? So you have to find the cause, and in this case the cause is not cardiac, the cause is the OCR. Alright? What is Waldorf classification? I've just discussed the Waldorf classification. Please go back and watch the Waldorf classification. It is not Waldorf. I have discussed this in this session. It is for condylar hyperplasia. Yes. So it is Waldorf classification. Waldorf classification of condylar hyperplasia. It's already discussed. Please go back. Calcify technique is discussed multiple times in multiple sessions. A lingual split technique to remove the lingually tilted lower third molars. It's discussed multiple times. Alright, and yes, it is asked in INI. So we have taken it in recall. We have taken it previous year in the session. And I don't want to repeat the same things again. Alright, so with that, we complete all the important questions for this year. I wish you all the best. If there are still doubts, we have doubt sessions coming up. We have morning motivation sessions where you can ask any doubt in oral surgery. And just like that, you can ask any doubt in any subject in these sessions. Alright. So all the best. Yes, Waldorf classification is important. We have taught it in the class. It's there in the recordings. It's there in the notes. So definitely you should. It's important, which is why I have taught you in the most important topics. Right? So please read it for INI-CET. Might not be asked in NEET, but definitely INI, it is very important. Alright, Karati? Okay. So with that, we'll end the session here. Thank you so much.